A very good morning to everybody. I think it's 8:01. And today we are very fortunate to have a pediatric session. And in the first, we would be having our young speaker from the Department of Paediatrics, followed by Department of Anesthesiology, where incidentally, we'll also be having a pediatric topic for the anesthesiology topic by Prof. Okay, and without further ado, I'd like to introduce our speaker, medical lecturer, Dr. Hanaa Mardhiah. And Dr. Hanaa graduated from Masters in Pediatrics in 2021. And she is now undergoing general pediatrics training and now with an interest in neonatology. And she's been with us in the neonatal ICU for a couple of months now. Okay, and we were struck by something that was very uncommon recently, or is it common, which is the common cold. Okay, so I'd like to call Dr. Hanaa Mardhiah to share with us the NICU experience of the common cold.
Good morning, everyone. Thank you very much for joining us bright and early on this Wednesday morning. The title of my talk is Struck by the Common Cold, which I will be discussing from the perspective of a neonatal intensive care unit. So in my talk this morning, I will share a case vignette to illustrate the potential severity of human rhinovirus infection in preterm infants. I will then discuss respiratory viral infections in the neonatal intensive care unit, the impact of such infections, and the measures that are currently being employed to prevent these infections. Before I begin, I would like to give a brief introduction to the neonatal intensive care unit, the NICU, in UMMC, for the benefit of those who have not had the opportunity to visit us. The NICU is located on the first floor in the obstetrics wing of KWKK. We are a level 3 intensive care unit, and this is defined as a consultant neonatologist-led subspecialty intensive care unit. We are able to care for a total of 27 neonates at any one time, and our patients are accommodated in 2 open spaces, as seen in this photograph, as well as 3 isolation rooms. And to our NICU is about 450 patients, 90% of whom are inborn. So I'd like to share the story of baby A. Baby A was a male infant who was born at 30 weeks gestational age due to selective fetal growth restriction in a monochorionic monoamniotic twin pregnancy. So he was the affected twin. He was born with an extremely low birth weight of 905 grams. And in the initial admission to NICU, he usual complications of prematurity, namely respiratory distress syndrome. For this, he received 1 dose of surfactant via the INSURE technique. For those who are not familiar with this technique, INSURE is an acronym for intubate, surfactant, extubate. So it aims to provide surfactant with a minimal duration of invasive ventilation. And in fact, he was only ventilated mechanically for 12 hours. He was subsequently ventilated with non-invasive positive pressure ventilation. He developed moderate bronchopulmonary dysplasia, whereby he required oxygen support for 58 days. By 36 weeks of postmenstrual age, he was ventilating on low-flow nasal cannula at 2 liters per minute on room air. And by 37 weeks of postmenstrual age, he was self-ventilating on room air. Unfortunately, baby A became unwell on day 62 of life. He developed apnea. However, between those episodes of apnea, he was still fairly active. So the common practice would be to presume that this is a new onset clinical sepsis, usually of a bacterial etiology, and he received antibiotics for that reason. Due to this period of being unwell, his respiratory support increased from self-ventilating on air, as previously described, to nasal CPAP. 2 days after the onset of his illness, he rapidly deteriorated, where he became lethargic and unresponsive to stimulus, with multiple episodes of apnea. So at this point, there was further increase in his respiratory support. So from room air to CPAP and ultimately to invasive ventilation, he had severe respiratory acidosis requiring high-frequency oscillatory ventilation. There was evidence of organ involvement. There was transaminitis. There was evidence of bone marrow suppression secondary to sepsis. He had thrombocytopenia, normal platelet counts at the onset of illness, but it dropped to a nadir of between 6 to 8 by day 3 of illness. He required 5 platelet transfusions, approximately 50 mils per kilo, before the platelets stabilized on day 8 of illness. And also there was evidence of an inflammatory process. His CRP raised from 3.93 to 15. So what we were dealing with was a preterm infant who was relatively well and was gaining weight, and we were able to wean his respiratory support, but he suddenly and rapidly deteriorated with multi-organ involvement. So our thoughts here was this a new onset sepsis? Was this sepsis of bacterial origin? The antibiotics had been started empirically 2 days prior to this rapid deterioration, and the blood cultures which were taken on day 1 of illness showed no positive growth at 48 hours of incubation. So what was interesting was that when he rapidly deteriorated on day 3 of illness, he was, if I share with you this diagram, he was in bed, in the red bed labeled 1. He became unwell on the 13th of January. Then the patient next to him became unwell subsequently, and the patient opposite that patient became unwell as well. And both of these patients, patient number 2 and patient number 3, became unwell on the 15th of January, which coincided with the day that he rapidly deteriorated and required intubation. Then we thought, it has spread really, really fast. Could this be a viral infection? And could it even be COVID? Now, the reason why we considered COVID as a potential etiology was based on our pediatric experience with COVID infection, as well as multisystem inflammatory syndromes in children and in neonates. So we thought of testing for COVID. And at this point, we had 2 options, whether to send for a real-time polymerase chain reaction, so RT-PCR, or to send for the biofire respiratory panel, which includes the COVID virus as well as other respiratory viruses. So in the end, we selected the biofire RT-PCR due to the faster turnover time. So interestingly, biofire respiratory panel came back for human rhinovirus/enterovirus, and therefore a diagnosis of human rhinovirus was provisionally made. So the top half of this slide, part A, shows the first 3 patients who became unwell. And on the right side of the top diagram, there is patient number 4. Patient number 4 was asymptomatic and not in contact with the first 3 patients when they all first became unwell. However, on the 20th of January, when patient number 4 was de-escalated from NICU to SCN, he also developed similar symptoms. So these are the clinical characteristics of the patients who were all tested positive for HRV infection. All of them were born at very preterm maturation, so between 29 weeks to 30 weeks of gestation. All of them were at least, were less than 2 kilos in weight. So we had 2 extremely low birth weight infants, and we had 2 patients who were at the threshold of being very low birth weight. What was striking was that all of these patients developed recurrent apnea, and all of them required increase in ventilation support. Some of them had comorbidities. Patient number 2 was preterm at 31 weeks, but did not have comorbidities. So the comorbidities that we observed in these patients were BPD, as well as acyanotic congenital heart defects, namely PDA and PFO, which were not hemodynamically significant. So what happened to these babies? Well, they required increase in ventilation support. Now, patient 1, baby A, was a patient who had the most significant symptoms. So he required invasive ventilation for 8 days. However, he made full recovery. So by day 9 of illness, we managed to extubate him and allow him to self-ventilate on room air. his transaminitis resolved, his thrombocytopenia resolved, and he is currently being prepared for discharge. His blood cultures and his fecal cultures yielded no growth, so it was only the human rhinovirus infection that he tested positive for. The other 3 patients did not require intubation. The highest ventilation support that all of these patients required were CPAP, which they managed to come off fairly quickly. So for patient number 2, she was self-ventilating by day 3 of illness. Patient number 3 required CPAP for a little bit longer, was only able to wean to room air by day 12. And patient number 4 was on room air by day 6 of illness. Patients number 2, 3, and 4, interestingly, had positive tracheal culture growths. So they had Paediatrics, which are common organisms in our NICU at the moment. So we've got Klebsiella and Pseudomonas, which were sensitive strains to ceftazidime, cafepime, and tazocin, which this patient and these patients received cafepime for 5 days duration. Their blood cultures yielded no growth. The human rhinovirus infection, what do we know about it? It is the common cold. It is transmitted through direct contact or aerosol, and it is historically known as viruses of older children. For the time being, it is not thought to be a significant contributor to illness in infants. However, there is increasing evidence that HIV infection can cause severe illness in the preterm or in preterm infants as well as in newborn infants. And studies are beginning to show that it is the most frequent cause of acute respiratory illness in very low birth weight infants following discharge from the NICU. And the HIV virus is the most frequent viral etiology of bronchiolitis and hospitalization in PLBW infants following discharge from the NICU. And what's interesting is that in very low birth weight infants, HIV affects them more commonly than RSV. Also, bronchopulmonary dysplasia confers a relative risk of 2.18. So human rhinovirus can cause severe respiratory disease in infants who are admitted to the NICU, and the dominant clinical signs have been reported to be nasal congestion, nasal discharge, and increased work of breathing. So fairly similar to a child who does become symptomatic of this infection. However, we feel that nosocomial HIV infection may be more common in neonatal care facilities than previously recognized. And there is increasing knowledge of this due to the availability of PCR tests. So what has been reported in the literature in terms of HRV outbreaks is fairly limited. There are at the moment 5 published studies, and all of these are mainly in developed countries. What they describe is that these patients who develop rhinovirus infections will require increased oxygen supplementation. So they are more symptomatic than bigger children. And some of them also present with apnea, which older children tend not to present with. What's good is that infants who are infected with HRV all make full recovery, as reported in the literature. What about respiratory viral infections in general? It is thought that the prevalence of respiratory viral illness, or RVIs, in symptomatic infants during birth hospitalization can be between 6 to 30%. It is likely underdiagnosed as testing for viral pathogens is not routinely performed in the NICU. In infants who are evaluated for late onset sepsis, it is thought that the prevalence of RVIs is between 6.6 to 8%. So almost 1 in every 10 unwell infants with suspected late onset sepsis. And so far, studies have shown that in NICU infants, respiratory viruses can be detected in up to 52% of infants. So this is a table, and what I'd like to convey through this table is that there are infections of viral etiology in the neonatal intensive care unit, and that the prevalence, as I previously described, is between 0.6 and up to 52%. And the most common viruses that have been detected are RSV as well as the human rhinovirus. So outbreaks in the NICU. So apart from human rhinovirus outbreaks, there have also been influenza as well as RSV outbreaks reported in the literature. As expected, neonates and preterm infants are more symptomatic from these infections. They can have florid symptoms, bradycardia, desaturation, tachypnea, and apnea. And it has also been reported that some infants develop seizures as well as abdominal distension. What are the contributing factors to RVI outbreaks in the NICU? Limited data for now, but it is thought that family center NICUs, where siblings and relatives are allowed to visit and allowed to participate in the care of infants, is a possible risk factor. And there has been described increased incidence of viral infections, particularly when there are community outbreaks of RVIs. How does RVI outbreaks impact the NICU? Firstly, it causes an increase in the length of hospital stay. It causes prolonged ventilatory support. There is increased evidence of bronchopulmonary dysplasia development, and this can be seen in vitro studies as well as in observational studies. And infants who develop RVI, whenever there is an outbreak, will invariably be treated for nosocomial sepsis of a bacterial etiology. They would be started on antibiotics, and these antibiotics could sometimes be avoided. Outbreaks in general in the neonatal intensive care unit. So HAIs are up to 20 times higher in the NICU in limited resource settings such as ours. In Malaysian NICUs, late onset sepsis affects 25% of the most vulnerable hospitalized infants, and organisms that have been identified to commonly cause problems are gram-positive bacteria like Staph aureus and MRSA, as well as gram-negative such as Klebsiella, as well as Pseudomonas. In our experience in UMMC, however, past outbreaks were bacterial in origin, and we had no previous viral outbreaks. So previous outbreaks in the neonatal intensive care unit, we have had the infection control team observe our practices and analyze our practices. And in the past, outbreaks have been attributed to contaminated express breast milk, contaminated sink in the milk handling room, as well as contaminated syringe drivers. In the literature, contamination of medications, IV fluids, TPN, ultrasound gels, and healthcare products have been implicated. There have been descriptions of transmissions from colonized healthcare workers, as well as transmissions from colonized infected mothers. So when these outbreaks happen, it does impact our practices in the NICU. It causes us to discontinue kangaroo care, which can be detrimental to the bonding between mother and infant, as well as the sharing of skin commensals, which can be protective in mothers from mothers to infants. And we had to discontinue kangaroo care during the COVID-19 period. Outbreaks can also result in cessation of shared milk programs, and if significant, it can result in temporary or permanent ward closures, which will affect the care of newborns in a particular hospital. The infection prevention measures. So what did we do following identification of the index case? Well, we re-emphasized hand hygiene. We got the infection control team to come, observe our hand hygiene practices, improve gaps in our practices. We immediately cohorted affected patients. We instituted staff protective equipment, for example, gowns and gloves for the patients who were infected with human rhinovirus. And unfortunately, we had to restrict visitors, and that resulted in parents not being able to see their children as much as they would have wanted. Other prevention measures that we could undertake would be active screening for colonization. However, this is contentious as we need to balance the risk and cost, the advantage and cost benefits. Environmental sampling has been done particularly during periods of outbreak. However, this is resource intensive and it rarely yields an outbreak source. So it confirms the presence of organisms on surfaces, for example, but it doesn't tell us where the source of the outbreak is. So infection prevention measures, as advocated by the World Health Organization, is a multifaceted approach. It involves staff education, parent education, patient isolation or contact precautions cohorting, discontinuation of kangaroo care during outbreaks. It advocates enhanced environmental cleaning as well as the use of single-use products. So it is multimodal, involves training and education of staff, personnel, caregivers. It advocates system change in terms of equipment, in terms of infrastructure and human resources. It employs monitoring and feedback, as we have done in our intensive care unit. It demands that staff remind and communicate well with one another. It also suggests or advocates culture change, whereby whereby we want unit leaders to become champions of infection control. In the future, what can we do to improve our quality management? We can identify and strain type outbreak organisms using various methods. We can perform whole genome sequencing, and this would allow us to distinguish background strains from outbreak strains. And annual vaccinations, particularly for influenza of healthcare workers and caregivers and parents, would protect our most vulnerable patients from influenza viruses, for example. So the take-home message here is to reevaluate the diagnosis of sepsis. Consider other diagnoses, especially when babies become rapidly unwell and if it occurs in clusters. In vulnerable infants admitted to the NICU, the common cold can cause morbidity and mortality, and the best infection control measure is effective hand hygiene. Thank you very much.
Thank you very much, Dr. Hanaa. So I hope we have learned from, as what Dr. Hanaa mentioned just now, what could be common was very uncommon in our NICU, and it could be something that was relatively undiagnosed before this. So I'd like to welcome any questions from the floor before we proceed to the next speaker. I don't think there are any questions. Okay, so there's one from, Prof. Tukusara asked, what is kangaroo care, please? Interesting learning, thank you. Okay, and the other question, okay, so maybe we talk about kangaroo care. Yeah.
Okay, so kangaroo care, like kangaroos and baby kangaroos, it is a care method where we allow babies to lie on their mother's skin. So when they're breastfeeding, for example, but not just during breastfeeding. So we place babies on their mother's chests. What this does is it enhances the production of oxytocin in the mother, so it creates bonding between mother and infant. And at the same time, by placing an infant on the mother's skin directly, it allows some degree of protection. It is thought that the mother's skin commensals would protect the baby, would envelope the baby or transfer to the baby to protect the baby and enhance the baby's immune system. The second question here by Prof. Mary, were the staff screened for rhinovirus during the outbreak? No, we were not. There were a few staff who had cough, colds, some UTI symptoms, but these staff were not screened for rhinovirus during this outbreak.
Thank you. In fact, actually, we thought it'd be good to actually screen all the other babies, but we decided not to. We actually didn't screen the staff nor the other babies, but the other babies, the ones who were in the HQ, were cohorted in one room in the same area, and we gave strict instructions that if, let's say, for example, they were symptomatic, then we will screen them. Okay, I think it's okay. Yes, very interesting. If you want to continue to whole genome sequencing and transmission network analysis, please let me know. We've done it before. Yes, we actually wanted to do this for a group of babies. Unfortunately, the samples were discarded after it was positive. So I think it was, we were a little bit disappointed because we thought we could actually resume and do this, but we could not. Yeah, we couldn't type. I think one of the things that we probably can highlight to the microbiology team in future is that if there is something that we think is a little bit strange and has not occurred before, then probably the samples can actually be flagged as to please keep these samples and not throw them away. Oh, then 2 more questions. No, yeah, I think that's all. So I would think that the lesson learned from here is to recognize something that is different from before, and also to ensure that we always maintain hand hygiene, no matter what. And if, let's say, you have snuffles, whatever, to raise this concern and inform others in the team as well, especially if you're looking after vulnerable group of population. Okay, I think we'll move on to the next speaker. Thank you very much.